Calcium plays an important role in intracellular and extracellular metabolism, controlling such processes such as nerve conduction, muscle contraction, coagulation, electrolyte, enzyme regulation, and hormone release. Calcium metabolism in turn is tightly regulated by a series of hormones. On the topic of approach of hypercalcemia, we have a very informative talk by an eminent speaker by Professor Dr. Azeem Taj, who is Professor and Head of Department Medicine, Shaikh Zayed Hospital, Lahore, and Head of Division of Endocrinology and Diabetes. He has written multiple books on clinical examination and has contributed in writing guidelines for the management of SARS-CoV-2, and he is Head of Dengue and SARS-CoV-2 Unit at Shaikh Zayed Hospital, Lahore. I request Professor Azeem Taj to please come to the stage and give a talk on approach to hypercalcemia.
Assalamu alaikum. I think it will be better if we have an interactive session. I have made the slides so that you should actively participate. So, what is the objective of the lecture? After completing this lecture, a participant should be able to evaluate the patients with hypercalcemia. This is my main objective. So this is case number 1. So what is wrong with the patient? So I will read this case for you. A 66 years old lady, known case of type 2 diabetes on insulin and known case of hypertension, presented with vomiting and loose motions for 1 day following a dinner from a restaurant. Her CBC was normal. Other investigation revealed her burn was 18 mg per deciliter with creatinine 1 mg per deciliter. Sodium and potassium was okay. Calcium is 11.2 mg per deciliter. Bilirubin is 1 mg per deciliter, and ALT and ALP are normal. So what are your comments and what should be the initial investigation in this case? Anyone? So what is wrong in the biochemistry? So the calcium is elevated. So what should be the initial investigation in this case? Repeat the sample with serum albumin and if necessary measure iron. Because this is an actual patient. So what happens when you repeat the sample? Most of the times we will see in the next slide what are common pitfalls in measuring serum calcium levels. So in patient who has got dehydration, the serum albumin level may be elevated. So with elevation in the serum albumin level, the total calcium may increase. So we need to check it first before embarking on extensive investigations and expensive investigations. So, and if the calcium is elevated, you have to assess the severity of hypercalcemia. This is important because if there is severe hypercalcemia, then the management precedes the diagnostic workup. So these are some of the common pitfalls. For example, venous occlusion of arm during venipuncture may increase the calcium level by 1.2 mg per deciliter. So the correct technique is you apply the tourniquet and you puncture the vein and then you release the tourniquet and then take the sample. So even if the patient stands up from supine position, the calcium level may increase and even exercising before sampling may increase calcium level. So there are a few pitfalls in measuring of serum calcium level. So one should be aware of it. So with calcium and potassium, you do apply the tourniquet, but after puncturing the needle, you release the tourniquet and then take the sample. This is very important. So this is the calcium which occurs in about ionized form, free ions, which is about 45% of the calcium, and then there is protein bound and there is complexed. So the main thing to emphasize is the calcium is bound to serum albumin. So the changes in the serum albumin level can alter the calcium level. For example, if the albumin is low, the calcium will be low. If the albumin is high, the calcium will be high. So we have to adjust the calcium estimation, which is known as adjusted calcium. What I told my students is normal serum albumin level is, let's say, around 4. So you just add the decrease in albumin level to the actual calcium level. If it is elevated, then calculate it properly. So there are two formulas. If in millimoles, then you have to do this calculation, and if it is in milligram, so then it is the formula is in front of you. So basically, you have to add 80% of the decrease in albumin level to the calcium level. So and if there is problem, and you can measure the ionized calcium. So then don't require adjustment with the serum albumin level. So whenever you order the calcium level, you always order in conjunction with serum albumin, because the calcium has to be adjusted with the albumin level. So severity of hypercalcemia, so up to 12 is mild, and up to 12 to 14 is moderate, and 14 and above is severe. So if the patient has got severe hypercalcemia, you have to immediately start the treatment and do the diagnostic workup afterwards. So it is important in this regard. So the first step in the evaluation of calcium level is you have to repeat the sample, and then we will go to the next step. So usually the calcium some etiology of calcium, for example, calcium due to malignancy is severe because it is rapidly progressive, and hypercalcemia due to hyperparathyroidism and granulomatous disease is usually less severe, and because it is slowly progressive. And severe hypercalcemia is a medical emergency, as we have already talked about, and the treatment should precede the diagnostic workup. So this is the management. Volume repletion with isotonic saline. Normally we start at 40-50 ml per hour, and then we can give bisphosphonates, and if sometimes we have to do peritoneal hemodialysis to correct the calcium level. Now this is the second case. So a 57-year-old lady consulted you for elevated calcium levels. Her calcium level 1 month ago was similar with serum albumin of 40 gram per liter. No other abnormalities were noted on her CBC. You can convert the millimoles to milligram. If you are not familiar with millimoles, the correction factor is 4. So you can multiply with 4, so that will give you the readings in milligram per deciliter. So no other abnormalities were noted on CBC, electrolytes, LFTs and RFTs, renal function tests. She is known for migraines, osteoarthritis, hypertension and dyslipidemia. Her medications are atorvastatin 20 milligram per aurum, and amlodipine 5 milligram per aurum. And honestly, she described feeling well and denies having any family member with calcium abnormalities. Her vital signs are stable, and her physical examination is remarkable. How will you investigate? So what will the next step? Because in this patient, the calcium level has already been repeated once, and with serum albumin, so we have already gone with the first step. So what will the next step? The levels of parathyroid hormones, because we need to differentiate whether this hypercalcemia is due to with elevated levels of parathyroid hormone level or with decreased levels or low normal. So we divided the causes of hypercalcemia as elevated levels of parathyroid hormone or high normal parathyroid hormone levels, and low normal or decreased levels of parathyroid hormone. So measurement of intact PTH is the next step. So if the PTH is normal or high, a 24-hour urinary collection for calcium and creatinine is often ordered to assess for familiar calciuric hypercalcemia. So if it is low, then we will consider other causes. So the next, this patient has got primary hyperparathyroidism. His PTH level was elevated. So and is 24-hour urinary calcium and creatinine clearance is was normal. So in hyperparathyroidism, primary hyperparathyroidism, the urinary calcium excretion is more, although the parathyroid hormone increases the calcium reabsorption, but it increases the calcium level in the blood far greater than it increases the absorption of the calcium from the urine. So in primary hyperthyroidism, urinary calcium excretion is increased, but in familial hypocalciuric hypercalcemia, the urinary calcium excretion is decreased. So these are the causes of hypercalcemia with increased parathyroid hormone level. Primary hyperthyroidism, which may be sporadic, familial, or it may be associated with men, and tertiary hyperparathyroidism, and familial hypocalciuric hypercalcemia. So the causes of hypercalcemia with low PTH that include granulomatous diseases, for example, sarcoidosis, tuberculosis, multiple myeloma, hypercalcemia of malignancy. In malignancy, it may be due to the secretion of PTH-related protein. It may be due to osteolytic bone metastasis, or sometimes there is increased activation, alpha hydroxylation of vitamin D in the malignant cells, for example, lymphoma. So there are few endocrinopathies which are associated with hypercalcemia apart from primary hyperparathyroidism. These include hyperthyroidism, acromegaly, pheochromocytoma, and Addison disease. And there are some miscellaneous causes, for example, vitamin D intoxication, milk alkali syndrome, drugs, for example, thiazide diuretics, vitamin A intoxication, lithium, and prolonged immobilization can also result in hypercalcemia. So just a brief slide about primary hyperparathyroidism. It's not uncommon. About 1% of the elderly women, they had primary hyperthyroidism. So it is usually due to adenoma, sometimes it is due to hyperplasia, and very rarely due to carcinoma. So do order, because it's usually common in the fifth or sixth decade. So in elderly patients especially, do order serum calcium if the patient presents with aches and pains or the symptoms of hypercalcemia before giving calcium replacement. So the message would be to before replacing calcium and vitamin D, especially in elderly female, do check the calcium levels, because osteoporosis usually does not cause aches and pains, but hypercalcemia does. So tertiary hyperparathyroidism, it occurs in patients with chronic kidney disease, hypocalcemia due to decreased 1-alpha hydroxylation of vitamin D in chronic kidney disease results in increased production of parathyroid hormone. This is known as secondary hyperthyroidism. But sometimes the secondary hyperparathyroidism, it becomes autonomous and results in hypercalcemia. Then it is known as tertiary hyperthyroidism. In tertiary hyperparathyroidism, there is hypercalcemia. In primary hyperparathyroidism, there is hypercalcemia. But in secondary hyperparathyroidism, there is increased pH level, but the calcium level is actually low. Familial hypocalciuric hypercalcemia, so it needs to be ruled out. It's an autosomal dominant condition due to abnormality in calcium sensing receptor gene mutation. So if the PTH level is high normal, or in young patient, this disease should be differentiated from the primary hyperparathyroidism, because the treatment is different. Now this is case number 3. A 44-year-old shopkeeper, known case of HCV-related cirrhosis, presented with generalized aches and pains for 3 months. His CBC showed hemoglobin 8 gram per deciliter, platelets 80,000 per microliter, TLC was normal, ultrasound abdomen revealed splenomegaly ascites and a 4 centimeter focal lesion in segment 8 of the liver. Other investigations showed calcium 9.8 milligram per deciliter, bilirubin was 1.2, ALT was 26, AST was 36, alkaline phosphatase is 420, which is elevated. Albumin is 2.2, creatinine is 0.9, sodium is 132, and potassium is 3.6. So now in this patient, although the calcium level appears normal, but when we adjusted with the albumin, the calcium level is elevated. So in this case, we don't need to investigate further. We know that this patient has got hepatoma. We need to investigate the hepatoma, for example, with alpha-fetoprotein or biphasic CT abdomen. So hypercalcemia is one of the paraneoplastic manifestation of HCC. So the calcium level appears normal in this patient, and there are two things in the investigation which should be looking in patient with whenever the patient with chronic liver disease presents. If there is elevation in the alkaline phosphatase, that may be the only indicator hepatoma. So don't take it lightly. There is reversal of the ALT and AST ratio, which indicates the cirrhosis has occurred, and in the ultrasound also revealed space occupying lesion. So this patient has got hypercalcemia of malignancy due to hepatoma. So this is case number 4. These are all actual patients. A 47-year-old man presented with malaise, dry cough, and weight loss of about 5 kilograms in last 6 months. He had diffuse interstitial inflammation on chest radiograph. He was started anti-tuberculosis treatment on clinical grounds. His labs revealed hemoglobin 9.6 gram per deciliter, TLC was normal, sodium was 150, potassium was 4.2, creatinine was 0.9, and the calcium level is elevated. His intact PTH is low, albumin is 3.6. So this is a classical scenario. The patient has presented with hypercalcemia with low PTH. So we have to rule out granulomatous diseases. Although tuberculosis can present with hypercalcemia, the granulomatous diseases, the granuloma cells, there is extra-renal alpha-hydroxylation of vitamin D, which can result in hypercalcemia. But this patient was misdiagnosed as tuberculosis. This was actually a case of sarcoidosis. When we checked the serum ACE level, it was elevated. So we treated this hypercalcemia with steroids, which results in correction of the hypercalcemia. So in this patient, for example, in patient with granulomatous disease, we can measure the concentration of vitamin D metabolites. So we can measure vitamin 25 hydroxy vitamin D calcidiol or 125 dihydroxy vitamin D calcitriol. So elevated calcidiol is usually indicative of vitamin D intoxication, but elevated calcitriol may be indicative of sometimes the patient is taking activated vitamin D3, especially in patient with chronic disease, but it may be an indicator of extra-renal production, as in patient with sarcoidosis or lymphoma. Sometimes these two tests, measurement of serum phosphate and chloride. For example, in patient with increased PTH and patient hypercalcemia, it could be primary or tertiary hyperparathyroidism. So in tertiary hyperparathyroidism, there is hyperphosphatemia. In primary hyperparathyroidism, there is hypophosphatemia. So phosphate level do sometimes help. In vitamin D, increases both calcium level and phosphate level. So in vitamin D intoxication, the calcium and phosphate level both are elevated. But remember, in parathyroid hormone disorders, the calcium and phosphorus products remain the same. If the calcium is elevated, phosphate will be low. If the calcium is low, the phosphate will be elevated. So the products usually remains the same. So the serum phosphate level, they can help in differentiating primary and tertiary hyperparathyroidism, and also to differentiate parathyroid disorder from the vitamin D intoxication. Serum chloride is typically elevated in patient with primary hyperparathyroidism. Sometimes we do the chloride and phosphate ratio basically to differentiate between parathyroid hormone related causes from the non-parathyroid related causes. PTH related protein, usually the malignant hypercalcemia, the cause of the malignancy may be obvious at the time of the diagnosis, but sometimes it is not obvious. So we can check the parathyroid hormone related protein levels, and then we can also check the level of vitamin D metabolites to look for the cause of hypercalcemia in patient with low PTH. So this is case number 5. A 66-year-old man, known case of diabetes, hypertension, chronic kidney disease, and ischemic heart disease, presented with malaise, generalized weakness, and aches and pains for 2 years. His recent lab revealed hemoglobin 8.6 gram per deciliter. TLC was normal. Sodium is actually 144. Sorry for the typographic mistake. 1440 is not possible, and the potassium is 5.2, the creatinine is 3.9, and there is elevated calcium. I have seen quite a few cases, sometimes overlooked by the nephrologist. Even in patient with chronic kidney disease, the normal calcium level is abnormal. So we must suspect in this patient there is hyperphosphatemia. So this patient could be a case of tertiary hyperparathyroidism. So we will check it with parathyroid hormone level. In this patient, actually the parathyroid hormone was low. So we investigate on the line of multiple myeloma. So actually the diagnosis was delayed, resulting in the renal failure, and unfortunately the patient ultimately died. But it is frequently one of the presentation of multiple myeloma is with renal failure and with elevated calcium level. So this is an we have seen one patient with many patients with tertiary hyperparathyroidism with the similar presentation, but the main thing to be considered in these patients are multiple myeloma. So this is the summary. Approach to hypercalcemia: confirm hypercalcemia, verified with repeat measurement, total calcium corrected for albumin or ionized calcium, clinical assessment to look for etiological clues, and measure parathyroid hormone level should be the next step. So if there is parathyroid hormone is elevated, it is usually due to primary hyperparathyroidism. Mid to upper normal, rule out familial hypocalciuric hypercalcemia. If it is low normal or low, then consider granulomatous diseases, malignancy, multiple myeloma, and other diseases. So I will skip these slides and have a nice day. So if there are any questions, I will be more than happy to answer. Thank you.